Thank you, Dr. Puglisi. And I just want to get a time check, Jesse. Okay, thank you. So just before we open up the floor for questions, I just wanted to take a little moment to kind of sum up what was just said. Thank you, Dr. Puckreen kind of started us out where he kind of further delved into the disparities and the history of those disparities when it comes to criminal justice and the healthcare system. And Ms. Scott talked about how how we can learn from FQHCs and how they have eliminated disparities in healthcare, as well as how certified community behavioral health centers can learn from FQHCs and begin to partner with not only FQHCs, but also other partners within the broader community. And Dr. Puglisi left us with a great case example of what's happening in Connecticut around addressing the healthcare needs of justice-involved people in the community. And so I would like to open up the floor to any questions that people might have. Yes, in the back.
I have a mic.
And Jesse has a mic coming.
My name is Taylor Nivell, and I work for Disability Rights DC at University Legal Services with the Jail and Prison Advocacy Project. These are my colleagues. I am a returning citizen. I spent 4.5 years in prison, and I have a complex psychiatric disorder, I have PTSD. And so one of the things I noticed that we keep talking about is working with the community-based providers. I work with Community Connections. I have a job. I'm considered high-functioning. Went into foster care. And what I keep seeing at these panels is a lack of representation of people like me. You can't do the work if you don't bring me to the table. You can't do the work if you don't start with the criminal justice system. Because you have judges who say things like, you have this disorder and you can't be helped. That was told to me. So when we talk about building a system that's treating people with psychiatric disorders, I strongly feel that it goes beyond just treating the person, because we have to treat our society. And when you have a lack of information, and we keep talking about the preschool to prison pipeline, let me give you some statistics for women, because we always forget about the women who are incarcerated. 95% have been victims of domestic violence prior to going to prison. That's the federal system. 68% have witnessed violence prior to going to prison. 75% have been victims of sexual abuse before they go to prison. We're talking about a trauma to prison pipeline, and you have to create a trauma-informed justice system. And don't just treat me when I get home, treat me before I even get there. Treat me while I'm in the prison, because I can tell you, and I've written about this in the Post, I've written about it in talkpoverty.org, I came out of prison worse than I went in, and I didn't deserve to be there. And the community support workers can do a lot, but what we're forgetting is accountability. You can dump all the money you want into these organizations, but if there is no accountability, and trust me, I know, I have to move once again because I have a voucher, and nobody's holding those organizations accountable, DVH and everybody else that's involved. So when we really, really talk about this, it's a multi-pronged approach, and it's not just focusing on the mental illness aspect. You educate your judges about trauma-informed care. SAMHSA has a wonderful program. You educate your defense attorneys, you educate your prosecutors, and then you educate your community support workers, and then we can attack this problem.
Thank you for that comment. I'm going to address that comment. Thank you, ma'am. Next question, please.
Thank you, and I'm glad this woman spoke, because sort of taking the pain that I'm feeling first of all, I'm surprised. I was supposed to be on a panel. I didn't even receive staple. They didn't have me down. And I was here in April, 20 months ago for the first time. And somewhere, something went wrong, because I'm in awe right now. My name is Barbara Dennis, I should have said. Mothers of Those in Crisis, who has been advocating for families that have family members in the justice system because my son I've been pleading for him for 36 years. I started pleading for him before he ever committed a crime, before he ever got arrested. I addressed what I was just learning in his mental health problems, the things that was going on, substance abuse. He is now approaching his 56th birthday, and he was maliciously prosecuted in Buffalo, New York, which I can say anything right now because I'm just in awe how everything is not the way I thought it was going to be. And our organization has been done through volunteering basis for all this time. We've never stopped to get a dime. So for me to make all the plans and do everything I did to get here today, and somehow, and I have all the facts at home, I'll address, I call it Coach, you know, because I look forward to them. Because before I came here to this kind of event, I'm in awe. I'm feeling a lot of pain right now because I wonder who made such an error, and I have all the facts. But what I want to say is this lady is speaking volumes. And what I have to say, it'll just have to go into my book that I'm about to write because, like I said, my son is approaching his 56th birthday. He is in Dannemora. He is there because he was beaten by a correction officer in Attica, and I know that's because they know by now it's all over but the shouting. I've got all the evidence and the facts that he was maliciously prosecuted by, well, hey, I'm not going to take up your time. Just listen out for Barbara Dennis and Mothers of Those in Crisis, and I'm really just surprised. I mean, they wrote and asked me if I would be on this panel. They named the people. And when I get here, they don't even have something, you know.
Can I speak to both of those?
Yes, of course.
I appreciate hearing both of your personal stories, and I agree, you know, it's not the solution, but another thing I would say is that I agree that education is a huge part of it. You mentioned judges, attorneys. My own interest is in educating providers, so pediatricians, right? People before, the time to really get people is before the age of 10, when they start developing ingrained personalities. So we're talking about getting children. Educating children with incarcerated parents have much higher rates of incarceration themselves, same with mental illness. And we're talking about getting people at young ages and seeing what they need, offering trauma-informed care, getting them support services. And really, it's about prevention. You know, I'm a primary care doctor, so I'd rather not see things happen. I get measured on what I prevent from happening. And I think educating our entire healthcare workforce about this so that we're not only taking care of people appropriately post-incarceration, but at much younger ages to really prevent that from happening. And you made me think of one other thing. Oh, I didn't talk to you about Jermaine Lyde, who's the female community health worker I work with, who we only recently got funding to hire, specifically for the reason that women coming out of prison are remarkably more exposed to violence, intimate partner violence, and trauma in their lifetimes. And it's really about, you know, you talked about your horrible experience with healthcare and just your experience in general in prison, which is not uncommon. And it's about changing that experience from the healthcare point as well inside, so that it's not a additionally traumatizing experience. And we work, you know, one of the benefits of being a physician that I see is, you know, being able to advocate for people. So getting involved with state legislature, getting involved with Medicaid funders and helping them see, you know, what should be funded. These are our obligations.
So, Lisa, I have a question for all of you and for the panel. I think what we hear about in listening to you and listening to the questions is the extent to which trauma pervades this space. And we have here a new provider type that by definition has to be a trauma-informed provider type with a recovery model that exists outside the four walls. I think the question I would ask, Malvise, going back to your 50-year story, Gary, your hundreds of years story, Lisa, the rapid change you've shown at Transition Clinic, is realistically, if we can get CCBs off the ground and we can scale them nationally, can we really make a difference? Can this really impact in a trauma-informed model that has an outside the four-wall reimbursement structure? Can it address these profound issues of trauma and dislocation that I've heard us all talk about? I think that's my core question.
The answer is yes and no. Yes, in that it's doable. And this is a great start for doing. The difficulty we have is that we don't have 50 years to get it done. Both because sustaining the interest and the commitment will be an issue over the long haul. But it's also the fact that this health system will generate competing activities and interest over the years. And to the extent we figure that, well, we can wait till somebody else does, add some more centers or makes more money available, we can't wait. I do believe this is something that can work, should work if folks don't get competitive and decide they want to compete with, as opposed to partnering with other entities in their communities, and look at how to replicate some of the things that have been done before and that are going on now.
Gary, Lisa.
Yeah, I think part of the challenge is that we're actually not talking about one-off events. We're talking about highly structured events that happen in very specific communities. And so what I'm saying to you is that these patterns that we are trying to get after, we need to put resources into those very specific communities. But we have to do it with a lot of thought. It has to be an integrated approach, meaning that as we talk to the prosecutors and judges, we have to educate physicians, we have to educate community. So what I'm suggesting is that in order to break these patterns, in order to create a new set of relationships that we'd like to nurture, we have to do it with a lot of thought. We have to do it with a lot of commitment. So the answer is yes, a program like that can make an important contribution, but we need to do it in a holistic way.
I think that's a hard question. The reason is that when you talk about trauma, you can talk about incident trauma, so an episode of domestic violence or sexual abuse, but you can also talk about generational trauma. So when we talk about whole communities of people that exist around the reality of a majority of those people having been incarcerated, you talk about effects in generations to come, effects of the incarceration of this current generation on their children. And that part will take a lot of time. But I think that it's doable in the sense that care now is better than no care. You have to start somewhere. So I think that sort of trying to terminate the cycle in one spot and almost go forward from there is the way that it ends up working. Some of the effects will be seen immediately in certain patients with certain conditions, but the effects of the generational social effects on these people from having entire families that have been incarcerated will take years to see, I think. But it's a start.
Let me just add one other point to show you the possibility. So when we're talking about the African American community, 70% of African Americans in the United States live in 25 out of 38,000 zip codes. So what we're really talking about is 2,500 zip codes, and within those 2,500 zip codes, there are a subset of zip codes where we're seeing high levels of domestic violence, substance abuse, interaction with the criminal justice system. And so there are very specific and very targeted communities that we're really addressing. It's not like we have to run all over America. We can actually pinpoint, and that's the point I was making to you, that if we do this in a very thoughtful and very directed way and making sure that those communities get the resources, and in effect we reprogram them, but it will take a lot of challenges because we operate in a political system that is still very much informed by the past. That when you start talking about helping these communities, there are lots of people for all kinds of reasons, some of them historic, that don't want to do that. And so that's the wrestling match that we have right now.
And I think I was just going to add, you had mentioned, being trauma-informed within the four walls of a clinic, and you asked a question specifically about how we can get outside of the four walls. And I think the opportunity is it's a both kind of scenario where you're becoming trauma-informed within a clinical system, and you're also figuring out how within communities you can become more trauma-informed, because it's not everybody's going into the four walls of a CCBHC or an FQHC, but how can we really address the trauma piece that's happening in communities from birth to death. So that's just a comment that I'd like to add. And we have a question. Well, we have this lady here had a question.
Good morning. Thank you for having this incredible speaking event and amazing panelists. My name is Aleda Lanza. I am a co-founder of a company that we just came back from Stanford University. I was speaking at Medicine X about democratizing science and health. We have coded the complete science of applied behavior analysis so intuitively that a lay person without a master's degree or a 1,500-hour practicum can go online and treat themselves. We reduced the cost of ABA treatment by 40,000%. What used to cost $100,000 a year is now 50 cents a day. So as far as what I've been hearing, the presumption of the false binary, that the provider acts as a gatekeeper, whether it's in the four walls of these institutions or the licensed provider. If we can empower the consumer themselves with the nudges and the prompts to be able to achieve their goals, whether they're health goals or transition goals, this is the most effective science for behavior change without medication. So as far as the conversation that I would like to see is the conversation about the 99.9% of the population that don't have access to this treatment because we simply don't have enough clinicians. And so, I would love to see a conversation about how we can empower reimbursements to consumers to access care, but they have to do it with technology because there's no other means to access it. What are we doing about the population of Americans who, for example, for autism alone, the treatment rate of the primary treatment is less than 1/3 of 1%. This is the same thing for ADHD. It's also the most effective treatment for addiction without medication. So to be able to connect all of these communities and all these providers with a system that would be able to glean best practices and to be able to have a radar to say, well, when someone leaves a hospital, here's the patient compliance, or here, when someone leaves a trauma facility, whether it's an emergency room or a prison, that there is a technological support to be able to identify best practices across environments. So I'd like to invite your response. And one more thing, if I may, with regard to Dr. Pickering's astute observation with regard to the school-to-prison pipeline, I believe that accountability is absolutely needed. We do have standards. CMS has standards for home and community-based services for providers who provide these services. we've coded those standards. So we can scale those standards, beyond the provider, which is where, with regard to a couple of people who were asking questions before, they're asking the same thing. If we continue to have a model that acts as a gatekeeper, that disenfranchises access to care, and more importantly, for example, in our school system, applied behavior analysis, despite that, 2/3 of our entire grading system is behavior. There's only 1/3 of our education that is academic, except the standard that CMS has for behavior is not the standard that the Department of Education has for behavior. As a matter of fact, it is so egregious that a board-certified behavior analyst who adopts the disciplinary standard in any school in America would be subject to losing their license, because the restrictive programs that are in our education system have no therapeutic value, no treatment value. Therefore, how is it that we can have policies in our education system that would cause a behavior analyst to lose their license if they adopted that practice? Thank you.
Thank you for your comment. And yes, sir.
Jay Mansell from the Coalition of Behavioral Health Agencies in New York. My question is, there's been a policy that we've been advocating for in New York that I believe Connecticut has, and that is presumptive Medicaid eligibility upon release. It's sort of a two-part question. Is that what enables you to reach folks so early in the process? And are your community health workers, do they tend to be peers? And are you able to bill for them currently?
Game changer. Game changer. Over 85% of people being released from Connecticut corrections are enrolled. They are doing an excellent job with it, and it's all the difference. The second part was our CHWs. So are they peers? That's the sort of prerequisite. They're from the community. They're born and raised in that same neighborhood or the same city. They have had shared life experiences, which I think defines them as peers. Do you disagree? By definition, yes. That's a prerequisite, is their own criminal justice involvement in the past, which I had mentioned we see as the sort of the unifying life event for our CHWs and our patients. Can we bill for them? That's a difficult question right now. Not in Connecticut yet, is how I'll say that.
Ms. Scott.
One of the things about the prospective payment system is that there will, in fact, be the opportunity to include those costs in the description of what you're doing for patients.
Yes.
I will tell you historically that health centers at the very beginning had community health centers galore. I think at the center where I was, it was a very small center by comparison to some of the very much larger urban ones. We had 8. We had to stop because nobody was paying for them. We had to reduce the number. I had to go about making that happen for patients. One of the things that we were able to do with the advent of the prospective payment system is include some of those kinds of services that people were talking about innovative. We knew for a long time that worked. That wasn't innovative. We just need to get paid. So one of the things that happened is that we were able to do that. So yes, there will be that benefit, assuming the prospective payment plan continues.
Thank you. Question in the back. Yes. And then we have one here in the middle.
Thank you. My name is Tom Novak. I'm with the Office of the National Coordinator for Health Information Technology, and I'm also serving a dual role with the Centers for Medicare and Medicaid Services, where I focus on Medicaid interoperability. And I would like to speak to the presumptive eligibility question because it's excellent and something that I've worked to partner occasionally with Cochs and some other groups with on really trying to sell to state Medicaid agencies interested in pursuing it, because we sort of are in a very narrow window in time right now where the Affordable Care Act authorized eligibility funds to be utilized in a way that did not require a cost allocation across state agencies. So what you can do now for a somewhat short window is create a sort of a front end for eligibility that can put patients not only into Medicaid but into all other state services. And you could use 90-10 federal funds to support it for about another 18, maybe another 18 months or so. I believe it's till the end of 2017 that OMB waiver is in effect. So we have seen some states very aggressively taking advantage of that and trying to create this presumptive eligibility system where, as in Connecticut and elsewhere, some of the states are interested in using that ability to draw down those federal funds to really maximize their participation in all state programs, inclusive of but not limited to Medicaid, SNAP, LIHEAP, TANF, any sort of possible sort of demographic run system where you can build in this rules engine and push people forward. So that's something that we're having success with. It takes some buy-in at the state Medicaid agency level and often, if not always, at the governor's office. But a lot of times those silos don't talk to each other. So the state Medicaid agency knows this exists today, but the people in this room may not know to go talk to the state Medicaid agency about sort of creating that statewide architecture. So we're happy to facilitate those conversations and participate in those conversations as we can, but we also need some help in connecting the other sides of the house as appropriate. So that's a excellent strategy that Connecticut has and one that we are trying to scale in other states.
Thank you.
Thanks, Tom. I just want to make a few comments about that. One of these conferences are amazing is that we bring together for people from silos who never sit in the same room together. So we have people from healthcare, behavioral healthcare, criminal justice, and Medicaid and everything else. That's the blessing that Cochs has. But in order for that to be effective, those bridges have to be kept back in your local community. And I think, Tom, that's what I just heard you speaking to. Tom's been an incredible friend, an incredible advocate for us at the federal level. But it's at the street level that most of us live at that this stuff will play out or not play out. I think, Lisa, your example of the work that you do with your patients is a great example of that. But what I want to encourage folks to do is not just follow Senator Stebenow's advice of make sure you talk to one, if not two, of your legislators so that we bring the Excellence Act to 24 states and ultimately to 50 states, but to understand that crossing over between justice and healthcare means people speaking vocabularies that they don't generally know how to talk to one another. And that what's part of why we facilitate these types of conversations is to encourage this cross-network connection, for you all to understand that this relationship between criminal justice reform, health reform, and ending racial disparities are one big bucket. It may not seem like it, but it's one big bucket. And I just want to personally encourage you, when you go back to wherever your home is, to make sure that you continue this conversation locally, because it's an incredibly important conversation.
Thank you. And we have a comment right here in the middle of the room.
Where is that? Who wants the mic?
Hello, my name is Wallace Kirby. I work for Disability Rights DC. My colleague just spoke, Taylor Newell. I wanted to kind of highlight a little more, and I think it definitely needs to be highlighted a lot more what Dr. Puckrin had spoke about, particularly as pertains to poverty and the historical traumatization from that poverty. We got pockets right here in the District of Columbia, right? You know, a lot of us, you know, hear the buzzwords, public housing, low-income communities, you know, disadvantaged neighborhoods and whatever, you know. But I actually was raised in one of those public housing developments here in the District of Columbia, right? I was a student, right, before my family moved into public housing. However, once there, I had to take on a whole nother mindset. I had to have a psychological shift to actually be able to survive in that type of environment. And consequently, right, something happened, right, that kind of was a crossroads in my life, right? At 12 years old, right, the riots occurred here in the District of Columbia, right? You had the assassination of, you had Malcolm X, who was assassinated first, and then you had Dr. Martin Luther King. It was a moment in time that actually re-traumatized on a very deep level our neighborhood, because we were actually under siege by the police apparatuses, you know, and so forth, National Guard and whatever. We're standing there as young kids watching our parents get beat, get stoned and all type of stuff, right? And then they expected us to go back after that summer and just act like nothing happened in school and in the social arena. Well, for me, it didn't happen like that. So consequently, I ended up, right, acting it out in behavior. I went out into the streets. And I adapted a rebellious spirit as a consequence of that. And I had a abhorrence for the system that represented that type of abuse. And so consequently, while I was in this system that, you know, goes under the guise of being the Department of Corrections. And, you know, we need to even deal with that language, because are they really correcting behaviors in these facilities that they're sending us to, juvenile as well as these adult facilities? Well, it didn't do it for me. And what it did do was cause me to go into a deep psychosis that I ended up in a lot of mental institutions while I was incarcerated as well. However, going back to poverty, we need to have a greater dialogue, a greater commitment about how do we go about, you know, addressing this poverty in these neighborhoods that definitely has a correlation with people's psychic ability to endure under those type of circumstances. Because without that, you won't keep on having people who end up with a lot of mental health challenges, you know, unadjusted trauma. You're going to have a lot of individuals who are antisocial and so forth, who end up in these so-called correctional facilities where they're not getting this help. You know, regardless of what a lot of people come out, administrators of these systems, right, come out and do. If this was a business, which it really is, we wouldn't be investing in a failed system. We would be talking about actually abolishing that system and setting up a system that really is about health and reclamation and so forth. So we need to have a greater dialogue even about this historical trauma. You know, we keep throwing these statistics out about black people and brown people and so forth, but we're not really getting at the root of this poverty that's really related to the physical disability and psychological impairments.
Great. Thank you for your comment. I know we have about 1 minute in the panel. I just want to give each panelist just a few seconds to kind of close out and address many of the many comments that were addressed today. Ms. Scott?
I just have one comment, I guess. It has to do with what may be some resistance from Medicaid agencies about the prospective payments. Oh, sorry. About the maybe some resistance from Medicaid agencies about the prospective payment system. We have experienced, and I'm saying this as a part of my experience, from agencies that there was some resistance for that, and that continues in some. Not all, but in some. There needs to be a way to explain, for example, something that I'm getting ready to say, and that is that oftentimes the early services, in my case, primary care services, are more costly. There are more of them. They're more frequent, often. But in the long haul, the savings to the system is what you have to look at. Now, I recognize that that's a tough thing to do when your state budget is bleeding like mad. But there has to be an effort at looking at that. There was a study that was done with health centers from the University of Chicago. The data was from 2009, but the study is about 2 years old. And there was a look at 1.9 adults to see what happens for those health center patients compared to patients receiving primary care and from other provider types. The cost was 24% less over that period of time. 24. That's a lot of money over the long haul. It didn't seem like a lot when people were paying PPS. But one of the things we have to do better at is explaining the benefit. This is not just a one-time, one-shot kind of activity and program or commitment. You have to look over the long haul and make some determinations about whether we can let people know and get support for the program.
Great. 10 seconds, Dr. Puckarine, sorry.
That's all right. I just want to quickly address the young man's point back there with 2 points. First, if you think about it, there are people in the Muslim community today who are still fighting the Crusades. And a lot of what we see being acted out is, I'm just telling you the power of ideas and the power of social relationships and how they get sustained over time, and it may not look that way. The other thing I would say to him is that the system is actually producing what the system wants to produce. It is not that it's failed, it's actually doing what it wants to do. What you're asking is, we want a different system to produce different results. It's not that that system has failed, you just want something different.
Dr. Puglisi?
I guess my comment to what you're saying as well is that from my vantage point, I see all of that as health. So we know that socioeconomic status greatly impacts stress, which greatly impacts mental and physical well-being. My own sort of opportunistic approach is to put all of this under health. Health of people, health of families, health of communities, which encompasses what you're talking about as well.
All right, and thank you. Thank you so much for this rich conversation. Please join me in thanking our panelists today.